Hey everyone, let's talk a little bit more about ankle subtalar joint arthrosis, but also sinus tarsi syndrome. Now, I've lumped these all together because they're very similar protocols and extend from each other, but commonly they are interlinked, and that's something that I see quite a lot of. Now, as we start to look at this model, you can start to say, okay, well, yeah, there's quite a lot of spots that we're talking about, and these patients, they do typically need 20 or more potential injections because there is a lot, or injection points for the Valix points, but because there is a lot going on. Let's just start with sinus tarsi syndrome, and we'll keep it simple to start with. We're looking at this lateral aspect, and in particular, what I'm talking about is sort of coming around that lateral malleolus we're really wanting to hit, where we know that sinus tarsi syndrome is. Very commonly, we're looking sort of just around that sort of inferior sort of anterior aspect of the lateral malleolus, but also in that really nice area just to posterior and maybe a little bit more anterior of that lateral malleolus. Now, what I'm feeling therefore is, that fat tissue, and I've spoken about it previously with regards to, where there's fat, there's nerve, and where there's nerve, there's fat. And where we get that sort of spongy feel, as I do on sort of this specimen here, it means that I'm in the right spot there, and that's where I'm wanting to put the Valix point. And very commonly, I'll go to that area, and even if they're not tender, which commonly they are, that's where I want to drop some of the fluid, because I know that's where one of our nerves that's going to be coming down and through into that sinus tarsi is going to be, having some sensitivity associated with it. But I also don't want to forget, let's go a little bit more broadly around, let's follow that sural nerve up and, finding those spots along the way, very commonly, right around that lateral malleolus, but posterior as well. And then we're coming along through to our, superficial perineal as it's coming into the intermediate and following that up. Now, when we start talking subtalar joint arthrosis, it is going to typically present, and particularly if it's going to be sort of that posterior and middle facet, it's going to be coming a little bit more lateral. And then we start coming around and saying, okay, well, there might be a little bit of ankle joint arthritis, there might be subtalar joint arthritis, and if there's both, there's more than likely going to be some sinus tarsi syndrome as well. And remember, with our sinus tarsi syndrome, it's going to be really broad, vague pain. Very commonly, our lateral gutter ankle arthritis is going to present as sinus tarsi syndrome. And so we've got all these conditions coming together and melding together, and we're not too sure what's what there. And that's why this really extensive protocol, is going to be a really good option. As we start to come across, similar to some of our other protocols, we can really see that we're really looking at that saphenous for that medial ankle gutter, and into our tibial as well, as we start to pick up some of the influence, particularly on our flexor hallucis longus, as it's coming very posterior and deep, particularly if there's a stiter process of the posterior talus, that's where I'm starting to think, okay, well, what other aspects are happening here? Where do I need to concentrate? Because we know that, that not only, tendinopathy is happening, but then we get a lot of effusions and ganglions, that nerve sensitization. But of course, the anatomy changes as we get more arthrosis and change of the joint structure as well. Now, I've put a fair few of these on here because I do think, doing that more, comprehensively is a really important aspect. Now, not always do these patients get an immediate response, but most people do. Typically within that 24 hours, people are going to say yay or nay. The hard thing is, when you should do this, when you shouldn't, and when you should maybe refer on for, a more aggressive approach with regards to an ankle or subtalar joint arthrodesis. And then the other side is, if this isn't working, definitely get a corticosteroid injection, because it is very well evident. But for those patients that maybe aren't ready for that, then we've got this type of an option as well. Now, taking a step back when we think about positioning, I think seated's perfectly fine, having their leg moving in, having their leg moving in and out as well. Really get a good idea. People do typically tolerate these quite well, particularly with arthritis. These patients are chronic pain patients that, they're used to high levels of pain. They do respond quite well. They love it with the Hyperfix, but I tend to find that they don't last for as long. Commonly I say that 3 to 5 days is how long they last. These type of patients, when it's quite severe, they might only have pain relief for, 1 to 2 days. And in my experience, when they only have that shorter term relief and it doesn't doesn't prolong from that after 2 to 3, I stop there because I don't feel that any further injections are going to do any better than that. And that's when I'll start looking, okay, corticosteroid injection, or are we looking at surgical ostectomy or arthrodesis, as I mentioned. Now, let's not forget making sure that our mechanics are correct. You know, orthoses, looking at our laser therapy, and a great one where we can reduce the inflammation and then reduce the sensitivity. You know, remember our strengthening range of motion as appropriate, and some of our other interventions as well. But yeah, a really tough one that, you know, has varying responses. And, you know, I've sort of thought, okay, yeah, our ankle subtalar joint arthritis, it'll either respond or it won't. When we look at our sinus tarsi syndrome, this is a fantastic option for that. I would typically try and suggest to my patients, you know, a corticosteroid injection into that sinus tarsi is probably a better option to go with initially. But if that's still not resolving, or if they've got lower level pain where they don't want to look towards a steroid, that's definitely where I'm putting in the Lyftogt Prolotherapy, because it really does make that difference. But hopefully this has given you a little bit of a further idea about ankle and subtalar joint arthrosis, and of course sinus tarsi syndrome. Cheers.